Good morning. Thank you, Kaz, for inviting me. My topic is on difficult revision in ACLR case reports. So to start with the case, one is a 35-year-old male who has a history of trauma around 6 years back, presented to my OPD with pain, instability and locking. On clinical examination, the Lachman was positive, and so the two main tests which I look for is try to get an MRI to understand what exactly the pattern of tear. So there was a complete tear of the graft which was given, and was a cyst of the tibial tunnel. So the other thing which I really generally ask is an CT scan to understand the canal diameter of both the femur and the tibial tunnel, and to understand the length of the tunnels to get a proper view of my preparation for the next. So this case we planned for an arthroscopic ACL reconstruction. So while before going into the OT, after seeing this MRI, the preference, the things which came into my mind, what graft I am going to use, what will be the tunnel position, am I going to do it in a single stage or a double stage. So as I went inside, there was a lot of synovial tissues inside the knee joint. The meniscus were quite intact. I just got 6 minutes, so I have to fasten it. There was a lot of, the meniscus were intact, there is no problem in the meniscus, there is no evidence of any tear. Then the synovectomy was done, the ACL was tried to debride it as much as possible to, we read about remnant ACL, but is it really helpful in a already graft ACL is questionable. So I tried to preserve as much as ACL I could preserve, but when I was planning to do my whole preparation, I thought, I'm sorry for this, if I save the ACL remnant, will I get a good hold of the tunnel positioning? So I debrided the whole remnant of the ACL graft at the femoral side and at the tibial side, understanding that to get a proper image of the tunnels. So now you can see the tunnel on the lateral side over there. So I am trying to point my femoral tunnel. So I got a point here which is there. Then I put my bead pin, aim it to the tunnel, because what I can see, I am still far away from the posterior cortex and I am getting a good purchase. And once I do that, I ream it again with a 25, I drill it till 25. For all my revision case, I use a peroneus longus, because as we all know, it's quite tense and it is quite longer in length and gets a good diameter. So once drilling this, I was trying to see like whether I am confident now, and whether I've drilled, so I can see my drill bit is there, and also the previous tunnel are there in the position. I have not breached that bone bridge which is there. So once reaming it, I try to push the cortex. You can see the suture is not passing, going to the previous tunnel, and I put my bead pin. So there are two different tunnels which I managed to get. So whenever I plan for a revision case, I try always, I'm till now been successful in building a new tunnel some or other. Then to go towards the tibial side, we remove all the ethivans from there. There was some screws, as you can see the tibial post was there. Excuse me for the word spine, I think this is a mistake. So once the tibial side is done, that is removed, you can see all the ethibonds and the tibial post has been removed properly, and then next plan is to go ahead with the tibial tunnel. So I use an all inside technique in which I could place my new tunnel, and it gives me a better purchase because there is already a bigger tunnel, and here with the all inside technique I am saving much of the bone tissues. I am not breaching the outer cortex, so it is far safer for me. And once I ream it, as you can see, till now the thread has not passed to the other previously made the tunnels, so I am still in proper, and now my graft is passing nicely, and on full extension you can see it is there. Similarly, so technical errors for the reason for revision ACL is mostly 64.5%. The cause of trauma is 29.1%, and the biological phase is around 6.4%. So it can be a patient related, such as recurrent trauma or poor compliance with rehab, or too early to return sports, or biological related infection or failure of the graft encouragements, or sometimes surgeon related such as technical errors, improper graft selection and missed injuries. So this is again the few ratios which we can see, it's there all in the net. You just have to do a proper research, and for the risk factors for graft rupture is if there is hyperextension for more than 5, patient with high BMI, as a small narrow notch or graft impingement. This is another case in which I'll just fast forward it. After doing this, I have tried to use bone block as that was there. You can see with the bone fractures I have tried to put the bone block both at the femur side and at the tibial side. But in this case we should remember we have to ream the tunnels thoroughly and properly, curate it so that the bone plugs are well fitted and there won't be any site of infection later on. This is another case, third age, in which a patient is presented with knee swelling, pus discharge, knee stiffness and fever. I tried to find out the graft which the surgeon used was around 7 to 7.5. I called up the surgeon, can you please tell me, because they wanted to know. He said, sir, I used a 7 mm graft. So what next? So I debrided it completely clean, used this antibiotic stimulant, and patient is now doing fine, achieved his knee range of movement. Maybe next year I will plan it. So take home message, look for the cause of failure, beware of the subclinical infections, intra of culture of sensitivity is essential, counsel the stage revision to the patient, alignment coronal length surgeon is required, and plan for every primary ACL, look at the risk factors. Thank you.